suppose a patient has a monofocal in one eye, would
Yeah.
you do a synergy or eye hands in the fellow eye?
I would not put a synergy, because what happens is there'll be a lot of difference in the contrast, and the patient compares it because it's a diffractive IOL. Then some of them are not able to adapt a monofocal and a synergy. But you can put an eye hands, and if the patient is emetropic in in the first eye, then you can aim for about one diopter of target myopia, and give them some amount of intermediate and near vision, so that it reduces their dependence on glasses.
So, what is the next case?
Next case is a mid-dilating pupil. So I thought I would demonstrate the Maligan ring. Of course, this is about 5.5 millimeter. You can also kind of, if you are able to do the rexis, you can manage without the ring, but well, smaller than 5 millimeters, it's probably better to have a good exposure. Light nodiba?
So, I
More
see
light ಇದೆಯಲ್ಲ ಅಲ್ಲೇ ನೋಡ್ತಾ
this side port. Is this diamond?
This is a 1 mm diamond blade, which is sharp in the tip and blunt in the, so you can kind of fixate the globe when you make your main incision without losing the chamber.
Yeah.
So it saves you time, and you are able to fixate the intracameral xylocaine, xylocard matra. Okay. So it's important to use intracameral xylocard before using the Maligan ring. Light ನೋಡಿ. So this is the Maligan ring, which was again described by Boris Maligan. You just have to retract it from its holder, and
So, ideally, both the MyLoop and the Malucan ring should be used only once. But would you have experience of using them more than once?
you could probably ETO them, but the MyLoop gets locked out, so you can't really use it. The earlier MyLoop you could, but now the ones you're getting are disposable, and so you can't really reuse them. You have to, because after 5 clicks they lock, and once they lock, you can't use them. The Maligan ring, probably you can ETO them, clean them, ETO them, but again, sometimes they can get distorted.
Yeah, after reusing
If
them.
you use it.
Distorted.
So you just hook on to the loops are hook on to the iris, and these are the side ones, and then once that is in, then I take the dialer and then once you put them in, you can put it, you hook it in, and you can press it down so that it releases, and you have a nice good exposure. So especially in a floppy iris, IFIS, it's a great device to use, so you should always have it in your OR, and don't hesitate to use it, because sometimes the pupil comes down, especially in IFIS if there is a history of using tamsulosin.
Yeah.
So it is better in a mid-dilating pupil to use the Maligan ring, and also it's much easier to make the rexis a proper size rexis.
Yeah, I'm sure this size rexis you would not have been able to make through that pupil which you had earlier. Although I'm quite sure that if it was not for demonstration, you would have gone ahead and,
Yeah, because I do the rexis under the iris also.
Yeah.
But then, for all beginners, it is probably better to use a Maligan ring, so you have adequate exposure, and even if the pupil has a tendency to come down, then you are safe. And especially in cases of pseudo-exfoliation, typically you have rigid pupils, smaller pupils, and I'm using Viscoat again here. And you have denser cataracts in pseudo-exfoliation, and you have a lax zonules, so If you make a very small rexus, you can have capsular phimosis. Right, Nodima? So this is a chop. So the technique of direct chop is very important. How deep you are, your angle of attack, and the grip on the nucleus to get a direct chop. Some of them actually make a trench and then chop, but I'm comfortable doing a direct chop. Once you know the anatomy of the nucleus, the density, and a feel for the nucleus, then I think every case, irrespective of the density, you will be able to do a good chop. So that's the last fragment.
Even in the last fragment, I think you're controlling with your foot pedal. The chamber
Yeah,
is
yeah.
awkward.
Yeah, you can be gentle on the foot pedal and slightly come off. You also move slightly more towards the cornea in the antechamber so that if the PC suddenly comes up, then you can avoid a PCR. You can see that almost all the surgeons used a similar technique of chop, direct chop. Sheetal is among all of them, Sheetal is my oldest fellow. It's almost 9 years since since she did a fellowship, joined Netadama, and the senior consultant, Dr. Savio, probably 8.5 years. And Supriya is the youngest, uh, and they all trained under me. So their techniques are very similar to mine. And we have a long-term FACO fellowship program and also short-term training. And this is something that we also enjoy doing, teaching FACO, teaching techniques. So I did a little bit of hydro polish, open the bag with Visco, and this is again the iHands lens, which is a modified monofocal IOL.
So you use
Right,
the
Nodima?
push injector or the screw injector when you use these lenses?
Now this is something that has happened, which the lens is not. This is a screw injector. Load ಮಾಡ್ಕೊಳ್ಳು. The patient looked away. Visco ಕೊಡಪ್ಪ. The patient looked away when injecting, so then what happens is the lens can come out.
A patient moves on the other side, then also it's a problem because then you don't have
Yes, yes.
enough pressure or enough
Pressure. Yeah, you don't have the counter
counter traction is not.
traction because under topical they need to fix at the light. Visco ತಗೊಳಪ್ಪ. Visco ಕೊಡಪ್ಪ. The other thing is we're running out of. So you can see that is the end of the Visco. So if you don't inflate it adequately also, if you don't have a tight chamber, this can happen.
And the patient moves, so the counter traction is
Yeah.
not,
So now I'm going to see the patient is not fixating,
not fixating and moving inside.
moving inside. So ಕೊಡಪ್ಪ, Visco ಕೊಡಪ್ಪ.
So you normally like to implant your lenses under which viscoelastic?
This is HPMC.
PMC, okay.
So now I have put the injector in. and then I'm injecting it. The eye also is a little soft. Now you can see while pushing down the trailing haptic, the ring has gone in, right?
Yeah.
The trailing loop. So now how do you manage this? Because first you'll have to hook it out. I'll show you the technique. So when that happens, one loop is under the iris. And I think you can see that, okay. Now what has happened is the haptic probably has engaged that loop. So you just lift it up like that with visco. Then you just hook on the leading haptic, and what is that? That is the IOL. You can see the IOL haptic has got snagged there. So this is, you see the haptic is got caught in the ring. So then what you have to do is you cannot withdraw it. If you withdraw it, then you will have a problem.
Yeah, the lens will also try to come out.
Yeah. So now you have to dial the lens in, which I'm going to do. Push it to one side, dial the lens in. It's in the bag. Okay, now it's away from the, so this is something when you're using the Maligan ring, you should be careful. AC ಯಾಕೆ ಆಫ್ ಮಾಡಿಬಿಟ್ಟಿದ್ದಾರಾ? You can see the pupil has constricted further because of the manipulation. So removal of the ring, you can, she's got a slightly deep set eye also. So go in and then,
So basically that hook pulls it in, and when you have those rings,
yeah.
then you just.
So you can see that the pupil has constricted now completely. So I'm doing the rock and roll technique. You can see the lens is in the bag, well centered. And most of the viscoelastic is removed now. Now the pupil is just around 2 millimeters. Right, Nodima? Okay, small pupil. Iris also is little floppy, has a tendency to relapse. So then you go through the side port. Don't manipulate through the main incision, go through the side port. See that the IOL is stable. There's some amount of pigment release which is there, but that's fine. It will get absorbed. The advantage of the Maligan ring is that it does not distort the pupil. So you can see that the pupil again is round. I'm just adjusting the pressure. Okay.
I see this cannula that you're using, Sri Ganesh. What is this cannula? Doesn't look like a normal
See,
cannula.
what I do is, this is basically what I do is I use the 26 gauge needle.
Okay.
They just cut off the tip, so it gets converted into a cannula. I do this because many of the new cannulas, and I also use this, which is a micron filter, because many of the new cannulas, I get a lot of metal strads, and they're there. The next day you see it sitting in the wound, and it doesn't look very nice. And sometimes you get fibers from the syringe, plastic syringe. So I use this micron filter and this disposable needle which I converted into a cannula, and with that I have a very nice looking wound the next day. Otherwise, sometimes you see fibers, you see metal shards. Doesn't look very nice on slit lamp, though it doesn't cause any problem. Right. So that is the end of the surgery, and I think we demonstrated quite a few cases. Chanagideema.
Thank you. I
Thank
think
you.
a variety of cases, Sri Ganesh, hyperemia, myopia, loop, then small pupil, then mallusion vein, eye hand, synergy. That was a wonderful array of cases which you showed. Uh,
Yeah, and I think we are on time. Maybe just 5 minutes.
no, no, we are
But
perfectly on time. We are
okay.
perfectly on time, and so many cases in such a short time, 1.5 hours. Only Netrodhama can do it. Nobody else can do it.
Thank
But
you so much, and I would like to again thank AIOS, Dr. Namrita, Dr. Rajesh Sinha, J&J for conducting this webinar, Surginar, and so we could demonstrate different variety of cases, different techniques, machine parameters, different types of IOLs, and I hope you all enjoyed it. Thank you, and hope to see you again. Have a nice evening.
thank you so much, Sri Ganesh. It was just perfect. We had the most experienced people doing the live surgeries, and the youngest and the first live surgeries also, and that was to watch. So all the best to you, and thank you so much for allowing us to enter your OT and allowing us to see your OT from the comfort of our own houses and offices and laptops and desktops and mobiles. And I would like to thank each one of you, the entire OT team. I know would have it requires a lot of organization to do 7 cases one after the other, without even a break of 30 seconds. So that was the best part. And thank you, our audiovisual team, who did an immaculate transmission. The transmission was really very good. It was so clear. And of course, thanks to Johnson and Johnson for starting this program. It is all in your hands, and for sponsoring this program. This live teaching, which is, a program which is absolutely different. So thank you, Sri Ganesh.
Thank you. Thank you
Thank
once
you.
again.
Thanks so much.
Bye.